Buenos días, bonjour et bienvenue à toutes et tous. Good morning. Welcome to everyone and all of our panelists. Gracias a todos y todos por estar con nosotros esta mañana. Soy Shauna Hemingway, la ministra consejera de la Embajada de Canadá aquí en México. And now I'm going to switch to English. Ahora voy a cambiar al inglés. My name is Shauna Hemingway. I'm the Minister Counselor for Political and Public Affairs at the Embassy of Canada in Mexico. And I have the pleasure of moderating this next session. I would remind everyone that we have interpretation in both Spanish and English throughout the session. This session is public perceptions and risk communication strategies in the context of COVID. I'm honored to be moderating this panel of 5 fantastic experts who I have no doubt will have a great deal to share with us. This morning we have, first up is Mr. Benjamin Morgan from the Center for Crisis and Risk Communication in Calgary, Alberta, Canada. Then Dr. Sander van der Linden of the Social Decision Making Lab at the University of Cambridge in the UK. Dr. Saito Tomoya from the Department of Health Crisis Management at the National Institute of Public Health of Japan. And I have to say a special thank you to Dr. Tomoya to be with us today because it's very late now in Japan, of course. Dr. Kike Vasset, an expert in epidemiology at the Barcelona Institute for Global Health. Thank you for joining us. Dr. Melinda Frost, a specialist in risk communication and community engagement at the World Health Organization. Now this session will be shared across all of you. So please, if you could focus your presentation in 10 minutes. And I'll be monitoring the questions to see if we can have any follow-up on that front. So first up, I'd like to introduce Benjamin Morgan. Mr. Morgan is currently a principal at the Center for Crisis and Risk Communications in Calgary, Alberta, Canada. During a 16-year career as an advanced care paramedic, Benjamin Morgan also served as the Public Information Officer for the City of Calgary Emergency Medical Services. He holds a Master of Arts in Professional Communications at Royal Roads University. His research focused on the influence of social media on emergency management. His university experience led to a career change, and he is now one of Canada's leading crisis communication practitioners. Mr. Morgan has held communication leadership roles during 2 of Canada's costliest natural disasters and largest peacetime evacuations, the 2013 Calgary floods and the 2016 Fort McMurray wildfires. Thank you very much, Mr. Morgan, for being with us, and I'll hand the microphone over to you.
Gracias, buenos días. Gracias al Tahoe, Ambassador Clark, y a mi amigo Federico por la invitación a estar aquí hoy. Debo hablar en inglés y aquí mi español no es muy bueno. Gracias por la interpretación. Thank you for having me and for the invitation. This is such an important conversation to be having about risk communication as it relates to COVID-19, for the very fact that there's so much for all of us to learn during this global pandemic that hopefully will have resolution soon, and we can take our learnings and build better processes to make us a stronger global community. I have no prepared presentation except to share with you some basic considerations when engaging in risk communication. I have the great fortune to work with my mentor, Dr. Vincent Cavello, who has taught me a lot and encouraged me to look at things through different lenses, which is what I think I hear an undertone in the conversation today. What I would like to state is that as communication professionals, we must understand that high stress, high concern situations, so high stress, high concern situations, and I would argue that many people are very stressed and concerned about COVID. So when we find ourselves in high stress, high concern situations, the rules of communications change. We need to speak differently to our audiences. Dr. Rich Dr. Reich said it very well. We need to understand all of our audiences. Who are we speaking to? And there are multiple demographics of people that we need to connect, especially in a global pandemic. And each of those audiences need to be addressed perhaps in a different manner, in a different language, in a different channel. They all will have unique needs that we must give consideration to. What we do know through Dr. Cavello's research is that in low stress, low concern situations, the average human brain can remember and process 7 pieces of information. Back before we had to worry about area codes here in North America, the telephone numbers that were created were 7 digits. That was because we could, on average, remember 7 pieces of information. When we are feeling highly stressed and highly concerned, the average human brain can process and remember 3 pieces of information. So when we're in a high stress, high concern situation and we need to phone for police or ambulance, we only need to remember and process 3 digits, usually 911, depending where you are in the world. So we need to adapt that kind of thinking and that research to our communications and deliver 3 key messages. When people are in high stress, high concern situations, they will want to hear 3 key pieces of information. That's all they will, on average, be able to process, which is why I think you will have seen at the beginning of the pandemic, 3 key messages: wash your hands, cover your mouth when you cover your face when you sneeze, and stay home if you're sick. When we overrate, when we overdo our messaging, we can often leave our audiences feeling confused. If we give too much information at once, which is what I see happening now. I just watched a press conference this week from my government official, and they gave so much information, I was feeling confused. And the goal of risk communication is to help your audience feel confident in the decisions that are being made, to create a sense of safety, and to leave them understanding which behaviors that you want them to adapt, not leaving them more confused. If you do have lots of information, cut it up into smaller pieces and deliver it in different ways. The other key thing I think in risk communications is that Theodore Roosevelt said it many years ago, one of the United States presidents. He said that people want to know that you care before they care what you know. Your citizens want to know that your government cares about them. Your employees want to know that your company cares about them. They want to know that you're there for them before they give a care about all of the information you have to say. So out of those 3 key messages, it should always be front-ended with a message of care and compassion. In listening to the earlier panel, and then I'll wrap up, because I tend to be a mic hog, so I don't want to hog the microphone. We're talking about risk perception. Risk perception, I think, is really important as it relates to risk communication. It's the communications person's job to help translate all of the amazing research and science that's being done by the scientific community, to translate that into digestible communications so that the audience can understand the scientific research. That can tend to be a whole different language, the scientific language. And so it's our job to translate that into digestible and understandable information, which is on average a grade level 4. And if you think about who's doing the research, often PhDs, double PhDs doing this amazing research, we need to take that language and bring it down to about a grade 4 level for our general audiences to understand. Once we have that risk perception, so people understand that risk, I think one of the things missing from the conversation is risk tolerance. Everybody has a different risk tolerance. So when we're talking about masks as an example, or bungee jumping, if you put 10 people in the room, there will be a different tolerance for risk, even though everybody might understand the risk perception. So there's risk tolerance in this whole formula as well. Anyways, that's, I think, 10 minutes. So I don't want to take it up, and because there's really smart people on here to hear from.
Wonderful. Thank you so much. I think you raised a lot of good points and also reiterated some of the themes that we'd heard before about the human factor, and we need to treat people as individuals as they are. Also the trust and perception of risk. And I'll just take this opportunity just to thank one more time Pajo for organizing this, and the participation too of the Spanish, Japanese, and UK embassies here in Mexico City. Thank you so much, Mr. Morgan. We'll turn now to our second expert, who is Dr. Sander van der Linden, Associate Professor of Social Psychology and Society and Director of the Cambridge Social Decision-Making Lab in the Department of Psychology at the University of Cambridge. He is also on the management board of the Winton Center for Risk and Evidence Communication. He has won numerous awards for his research on human judgment, communication, and decision-making, including the Sir James Cameron Medal for the Public Understanding of Risk from the Royal College of Physicians. He is the editor-in-chief of the Journal of Environmental Psychology and the book Risk and Uncertainty in a Post-Truth Society. Thank you very much, Dr. van der Linden. I give the mic to you.
Thank you so much for that introduction. Gracias por tenerme aquí. I will be slightly unusual and go to a PowerPoint presentation as probably the only one here. So I will share my screen because I want to show you some data about COVID-19 risk perception. I'm hoping everyone can see this. I will proceed. If not, just let me know. For those who are interested, we recently wrote, and I think Paul summed this up real nicely, that to me, this pandemic, as to other social scientists, is just as much about human behavior and perception as it is about biology. And we wrote this review of what behavioral science has to say about how to communicate and change human behavior during those situations, including risk perception. And I'll talk a bit about the section on risk and some of the research that we've been doing. I mean, this was authored by many people in the field, but you may find this a useful resource as it's aimed at policymakers. So we recently published a paper looking at how people perceive the risk of COVID-19 around the world. And I want to show you some of that data. The countries that we looked at included the UK, where I'm based, but also the US, Australia, Mexico, Spain, Korea, and Japan, and China. So it was a broad stroke. It was during different times of the pandemic in different countries. So they had widely differing reported deaths rate at that time early on in the pandemic. So we have to take that into account. But broadly, we were inspired by Tedros' remarks that at the beginning of the pandemic, that we're deeply concerned both by the alarming levels of spread and severity and by the alarming levels of inaction before declaring a public health emergency. And our question was, at the beginning of the pandemic, are people perceiving alarming levels, or are people very different in terms of how they actually perceive the risk of COVID-19, and what social psychological factors could explain those differences? Now, before I'll turn to what might explain those differences, here's a map of risk perception. These were samples, national samples of each population, not probability samples, but quota samples matched on national quotas for gender, age, and ethnicity in each country. You see here that mostly people thought it was a high risk. So we measured risk by asking people, how likely they think it is that they might get COVID, how worried they are about it, both for themselves and other people, how well they, to what extent they think it's a big issue, a serious issue. So it was an index of many different ways of measuring risk perception, including cognitive and affective dimensions, which I'll come to in just a second. But you can see here that the UK, and you see that here, this is the mean and the distribution here of risk perception for each country. The UK came out highest. We didn't want to make a big deal out of this point, really, because it's a small difference. I think that the bigger takeaway, though, is that most countries were perceiving a fairly high risk, so a 5 on a 7-point scale. But there were some funny news stories, and I want to share this with you, just because of the way that we talk about risk, in the media on research on risk has a lot of misinformation too. And so there were quite some interesting headlines. Británicos y españoles están más preocupados por el virus que los italianos. And so countries started to compare themselves to other people in our survey, which was not really the idea behind our research. In the UK, you saw these headlines: coronavirus has turned us into a nation of scaredy cats. This relates to the fact that the UK had the highest risk perception. And I think this complements what Michael was saying earlier. There's a great deal of politicization around COVID-19. So people who tend to not be worried about the virus start politicizing it, and they even politicize academic research by taking, a finding out of context and writing about it in the media like this, which was a very interesting experience for us. That's just sort of a side note. What I wanted to share with you is my model of risk perception, which is very much inspired by all the work Paul has done over the last few decades, as well as others. And what I've tried to do is integrate 50, 60 years of risk perception research, different traditions of risk into one model. So a lot of risk looks at cognitive factors. How do people understand the risk? What's the likelihood that you'll get COVID, and how severe are the consequences? These are very common questions. Many people are interested in the cognitive dimension. I've primarily applied this to climate change and other issues, but I think it's a pretty general model. So it looks at people's, knowledge of a risk, but also their experience with it, which includes emotion and the affect heuristic, which of course Paul has written extensively about, but also people's personal experience, whether it's COVID or extreme weather events, which all goes into the way that we experience risk. And then the third dimension is social, cultural, contextual influences. So norms, what do people around you think in terms of how risky something is? People are greatly influenced by what other people think, and this is what we call the social amplification of risk, but also your values. And then I have a box here on individual differences, which includes factors like gender and politics and age and education. So controlling for these factors, I typically find that you can explain most of the variation in risk perception by combining these different areas of risk perception research. And that's broadly what I want to show you here. These are regression coefficients. So I'm predicting people's risk perception in all of these different countries based on variables that broadly map onto these dimensions. I'm not going to go into all of the coefficients. I just wanted to point out a few simple things. Across all countries, males are perceiving lower risk of the coronavirus. And unfortunately, we didn't have ethnicity. Paul Slovic has written extensively on the white male effect. And so we couldn't see if there was an interaction here with being both white and male. But certainly males are perceiving lower risk, which is ironic because males are actually objectively at a higher risk of COVID-19, even though they're perceiving a lower risk. The other factor here is whether or not you have experience with COVID-19, which was the single most important determinant of your risk perception of COVID-19. Have you had COVID-19, or do you know people who have had COVID-19? Which was one of the most important factors. And that goes back to the literature on how people learn through experience rather than numbers and analytics. Pro-Sociality was a measure we included that asked people to what extent they're willing to make sacrifices on behalf of other people. Again, across all countries, there was a positive effect. The more pro-social people are, the higher their risk perception, probably because it correlates with a dimension of risk that asked about the risk to other people. So the more pro-social you are, the more you care about harm to other people. If we break down the relative importance of these predictors, what's interesting is that in places like the UK, the predictors are actually quite different from other countries. So if you look at the UK, there is this tension between individualistic worldviews and egalitarian worldviews. And so those two are quite important. So there's this polarization in the UK that if you see the world as fairly individualistic, you care about yourself and freedom to do as you choose, your risk perception is much lower than if you're a more pro-social person. Whereas in other countries, more predictors are important. And so there's quite a bit of variation by country, which is interesting to note in itself. Now, the second part I want to talk about is how influential is your risk for getting a potential COVID-19 vaccine? So we asked people, would you get the COVID vaccine? Would you recommend it to other people? In all of these countries, and you see in the UK and the US, we had different platforms, which was just a methodological question. But you can see here that most people or majorities are willing to accept the vaccine, but it's also declining over time. As the issue has become more politicized, less people are willing to accept the vaccine. So that's an interesting trend. And substantial minorities of people just say outright that they don't want the vaccine, up to 37% in some countries, including the US and the UK. What I'm showing you here are the predictors. These are odds ratios. So the odds of you accepting the vaccine based on a whole range of predictors. One of the most important predictors of your acceptance of the vaccine is your risk perception. If you worry about the risk, this greatly enhances the odds that you're going to be open to a potential vaccine. But also factors like trust. We've seen here, we heard from Michael and others, the role of trust in experts, one of the most consistent predictors of people's willingness to get a vaccine alongside your worry across nearly all countries, whether or not people trust the experts. So the role of trust is really important here too. We've mentioned misinformation, an area I'm deeply involved in at the moment. We've also looked at people's susceptibility to misinformation about the vaccine. An index, we created an index of people's belief in lots of fallacious information about the virus. And we predicted what might lead people to endorse misinformation about the vaccine, whether it's 5G conspiracies or Bill Gates is going to track people with microchips through the vaccination scheme. And what's interesting is that in most countries here, including Mexico, Spain, the UK, and the USA, and Ireland, is what you see is that getting information from the WHO lowers your susceptibility to misinformation, whereas getting your information from social media increases your susceptibility, which is one interesting lesson. But also, we see the role of trust in science again. And here's the role of misinformation in predicting your vaccine acceptance. Again, misinformation has a clear negative effect on people's stated willingness to accept the vaccine. What I'll end with is some solutions. Here in the UK, we've been designing interventions to try to help people spot fake news. One of these interventions is called Go Viral. It's a 5-minute simulation, a social media simulation that allows people to learn about the reasons why misinformation spreads online and how they can spot it and how to not share it further. And the game is called Go Viral. It was done in collaboration with the Cabinet Office and the Foreign Office here in the UK, but also with the WHO and the United Nations. The United Nations done some wonderful promotion to get people to play the intervention. You can find it on the WHO website as well as a resource. The game is called Go Viral. And the aim is to help inoculate people against COVID-19. And it relies on a theory from the 60s in social psychology called inoculation theory, which is very much related to biological vaccines in the sense that people can generate psychological antibodies against misinformation if you preemptively try to nurture those in a simulated environment. So I'll end there, and thank you for your attention.
Thank you so much. What an interesting presentation, and for those slides as well. Some of the questions just for all of our speakers to consider if we have time at the end that are coming up. The role of civil society in terms of communicating on on these are non-government organizations and communications in crisis, how to communicate in a changing situation where the parameters and the impact is evolving, and also the role of communicators within a leader's response team. So in terms of the strategic response, how we position communication experts within that team. So I'll just put those questions out there as we turn to, as we turn to Dr. Tomoya, who is our next speaker. Dr. Saito Tomoya is the director of the Department of Health Crisis Management at the National Institute of Public Health in Japan. He is a distinguished expert in public health emergency preparedness and response, and serves as a member of the Cluster Response Task Force for COVID-19 at the Ministry of Health, Labor and Welfare of Japan. He is also a member of the WHO Review Committee on the functioning of the international health regulations during the COVID response. Before joining the Ministry of Health, Dr. Saito Tomoya was the instructor in the Department of Tropical Medicine and Parasitology, and conducted a pandemic flu surveillance study and a clinical research on a smallpox vaccine. Over to you, Doctor. Thank you for joining us today.
Thank you. Can you hear me? Okay. Thank you for inviting me to this very important seminar hosted in the other side of the planet. Even it starts from midnight in our time, I'm really happy to discuss this issue today. So I was working at the Cluster Response Task Force inside the government response headquarters to help government develop intervention policies. Today, I'd like to briefly mention the epidemiological status and measures against COVID-19 in Japan. And next, I'd like to introduce you the role of experts in public communication during the crisis. Then, in the last part, I'd like to talk about the experts' efforts on science communication, because especially on mathematical modeling, because this pandemic was the first time when the mathematical modeling was fully used for policy development in pandemic response in Japan. It was a remarkable effort and very historical actions. Here I show the epi curve. We identified the second imported case from China in the world following the Thailand on January 15th. In early February, we experienced a huge outbreak on the cruise ship Diamond Princess. It had more than 3,700 on board, and more than 700 were infected. And we observed many severe cases and deaths, even though we had yet observed around 10 confirmed cases at the time. The cruise ship outbreak was clearly a wake-up call for government as well as for citizens. This figure shows the result of the survey in the end of March. 23% of respondents said the Diamond Princess incident was the most important event influencing their precautionary actions rather than the alert and call for action from the government. Later in February, with the spread of the epidemic in the US and Europe, the number of cases in Japan also increased, and we started the denial of entry and reinforced quarantine measures. But due to the rapid increase of cases, government of Japan decided to declare a state of emergency under the Special Measures Act. Social activities were greatly curtailed and the number of cases decreased. However, from July, the number of cases increased again, peaking in late July and early August, and then decreasing again. However, the number of infected people could not be lowered significantly, and the number of cases increased again from late October. So currently, several prefectures are filling up their hospital beds and the situation is getting critical. Although not officially named by the government, July-August is often referred to as the second wave and the current wave from October as the third wave. But compared to the other countries of Northern and Southern American continent in Europe, we are controlling an order of magnitude fewer incidences per week and per million people. But on the other hand, it has not been as successful as Western Pacific countries like Singapore, New Zealand, and Taiwan, which strictly control this disease. The strength or advantage of disease control in Japan is a very strict test, trace, quarantine, isolation, and medical capacity developed under the infectious disease control. And we have very good access to hospitals and clinics. And we have more than 170 local public health centers conducting contact tracing all over the country. A major difference from Western countries might be the lack of cultural resistance or hesitancy to wearing masks. Even before the COVID-19, it was widely practiced to wear masks during the winter flu season, seasonal flu season, as a preventive measure. So we believe that wearing mask is widely accepted as a social norm in our country. And it has also been noted that there is strong peer pressure, and that is very effective in ensuring compliance with personal infection control measures. On the other hand, the problem is that measures are not enforceable. There are no criminal penalties for not complying with contact tracing, isolation, or quarantine. Nor can you take a curfew with fines and penalties like the city lockdown. Restrictions on the behavior of individuals and restrictions on the business of stores and restaurants are only under voluntary cooperation. So therefore, guiding citizens' voluntary behavior change and cooperation is the key for success. Therefore, communication was very important. So in the early phase of the epidemic from February to May, to confront this historical outbreak of new virus, I believe experts played a significant role in public communication. In general, the roles of the government and the experts recognize that the expert assess the risk based on scientific knowledge, and the government execute risk management and communicate with the public. However, in this case, the situation was changing rapidly and a quick response was required, but experts considered the government's action or response or communication was too slow. So thus, experts proactively engaged in public communication in the early phase. In this presentation, I'd like to mention the activities of the expert meeting, an advisory body to government of Japan, and COVID page, COVID Public Advisory Group of Experts, a private group of experts, including the members of this expert meeting. The expert meeting was established under the government of Japan response headquarters on February to give medical advice to government of Japan, and this was led by the director of NIID and Dr. Omi, the former regional director general for UPRO. And such a government advisory body usually only responds to consultations from the government, but this expert meeting prepared its own situation report and assessment and held a press conference to communicate it with the public. The expert meeting released a total of 15 perspective papers and situation reports and recommendations between February and May, and held press conference each time. So this is how the press conference is conducted. Sometimes it started after 10 o'clock in the evening, and by the time it was over, the date had changed. It was broadcasted live on the internet, which attracted a lot of attention. So one of the famous alert message called for by the expert meeting was the 3 C's. The Ministry of Health Cluster Response Task Force, based on an analysis of the clusters, called for these 3 high-risk environments: crowded spaces, closed spaces, crowded places, and close contact settings, to be avoided as places where many people are infected. So this is a message that I believe is quite ahead of the rest of the world on the need for the countermeasures for airborne infection, in addition to that for droplet infection, such as coughing etiquette, and hand washing. These 3 C's is widely known as sanmitsu in Japanese word. This word won the buzzword of 2020 award, the most popular word in the year in our country. It is not clear who actually named the keyword sanmitsu, but the governor of Tokyo, who pioneered the use of this word, won this award. So there is even an online game based on this award. As you know, Japan is famous for video games. So a lady is looking for the crowd, and they ask to control the crowd and ask them for the social distancing. So the expert meeting also proposed the detailed tips for reducing human-to-human contact by 80% during the state of emergency, calling it new normal as indicated here, such as the enhancing the shopping online or drinking online, or use remote medical services, or use Uber Eats or work from home, and etc. So these were intended to show an example of how to reduce human-human contact in daily life. But some people criticized it as an imposition of a lifestyle and not something experts should be talking about. The other efforts are from a private group of experts collaborated with media companies. So there was a sense of urgency from the experts that the government's communication was slow and not getting through. Therefore, in addition to the members of the expert meeting, a group called COVID page was formed, and we also included the communication experts and collaborated with many communication companies. And we set up a Twitter account and a very famous blog site called Note in our country. And here are the examples of the article in the blog Note. The articles and graphics were created with the intention of spreading to SNS sites aiming to penetrate the younger generation. The group published 41 articles and we got more than 4 million page views. And Twitter account has 160,000 followers. So this figure indicates that people are looking for easy to understand information and from the experts. So last but not least, let me introduce efforts on science communication from the experts in the cluster task force. So a cluster response task force was established in the Ministry of Health, and experts from national laboratories and universities collaborated to analyze the situation and make full use of mathematical models to estimate the effective reproduction number and projection of future epidemiological curve. On the other hand, the public theoretical background of the countermeasures was in the black box, because the task force was a part of the government headquarters and the members were difficult to communicate freely with the public. Therefore, some of them created a private Twitter account to gently explain the mathematical models behind the countermeasures and the basic concepts of mathematical epidemiology. The number of followers exceeded 400,000. But it was not enough, so doubts to experts were emerged. There were many complaints that experts were just threatening the public with numbers, like big number of reproduction number or expected deaths. So to communicate more directly with the public on the methods and theories of modeling behind the countermeasures, the professor provided an online lecture and via webcast and published and explained all the mathematical formula and published the code and data on GitHub. So despite the fact it was very difficult to understand with many complicated mathematical formula, but more than 50,000 people watched it on live and with more than 10,000 comments and 90% of them satisfied. And since then, some people started to calculate the reproduction numbers by themselves with that code, and criticisms of the calculation results have disappeared. That was quite effective. In summary, so today I talked about the example of proactive communication by the experts during crisis. This proactive communication by experts was done in part because of a sense of urgency about the weakness of the government's communications. There is a reflection that the experts has taken on some of the responsibility for the communication that should have been done by the government. This is also a risky action for experts. In the JEE, the Joint External Evaluation conducted by WHO in 2018, Japan had a good overall rating, but in this communication area, Japan scored 3 out of 5 in 3 of 5 categories. So we recognize that this area needs to be further strengthened even after 2 years of this evaluation. So thank you for everyone, and thank you for the collaborators with the communication expert for this presentation.
Thank you so much, Dr. Saito. That was really interesting and a good comparison between the approaches in different countries. We should all be learning from one another. Ahora voy a cambiar al español para presentar nuestro próximo invitado. Les recuerdo que contamos con interpretación de español en inglés. Nuestro siguiente panelista es el Dr. Kike Bassat, un médico especialista en pediatría, medicina tropical y epidemiología. Actualmente el Dr. Bassat es profesor e investigador en el Instituto de Salud Global de Barcelona. Su principal área de interés ha sido la prevención y el tratamiento de la malaria en la infancia. También ha trabajado en la descripción de la epidemiología y la etiología de las infecciones respiratorias y otras infecciones en países como Mozambique, Marruecos y Bután. Como resultado de la pandemia de COVID-19, el Dr. Bassat ha participado en diferentes estudios y ensayos de nuevos instrumentos para su prevención y tratamiento. También está investigando el comportamiento de esta infección en los niños, habiendo asesorado al gobierno español en cuestiones relacionadas con la COVID-19, pediátrica y la reapertura de escuelas. Muchísimas gracias, doctor. El micrófono es suyo.
Thank you very much, Shona, and I will switch to Spanish. En deferencia a todos mis colegas que nos están escuchando y que agradecerán oír un poquito de castellano. Intentaré ser muy breve y me interesa dejarle tiempo a Melinda Frost para que también pueda hablar hoy. Y me gustaría explicarles una historia muy cortita de cuál ha sido la percepción sobre el rol de los niños en esta pandemia, esperando que hayamos aprendido algo de los últimos 9 meses, porque realmente los niños han sido, por lo menos en España, a pesar de no ser los más vulnerables a la enfermedad por COVID, han sido de los más sacrificados dentro de esta pandemia. Si recuerdan bien, cuando empezó la pandemia, o la pandemia llegó a nuestro país, aquí en España, una de las primeras acciones que se puso en marcha fue el cierre inmediato de todas las escuelas y el confinamiento estricto de los niños. Y este cierre se hizo precisamente porque, como no teníamos demasiado conocimiento sobre cómo este virus afectaba a los niños y cómo se iba a comportar, utilizamos el modelo de otras enfermedades respiratorias virales conocidas, como la gripe, en las cuales el niño tiene un rol importante en la transmisión. Pensando que en el caso del SARS-CoV-2 el niño podía ser un gran transmisor, se cerraron las escuelas y se confinaron a los niños de forma muy estricta. Y los niños en España no tuvieron la oportunidad de salir de casa durante los primeros 3 meses de confinamiento, a diferencia de los adultos que sí que podían salir en determinadas circunstancias. Es curioso que, a pesar de que nuestro conocimiento sobre el comportamiento de este virus en los niños iba mejorando, los niños siguieron siendo los grandes olvidados de esta pandemia, y como parte de un grupo que asesoró al gobierno de mi país, se me encomendó una tarea que era intentar definir cuál era el rol a la hora de transmitir de los niños porque eso iba a tener evidentes implicaciones en la reapertura de las escuelas. Junto con mis colegas del Hospital Pediátrico Sant Joan de Déu en Barcelona, montamos una serie de estudios a nivel comunitario, un primer estudio en los domicilios de familiares de pacientes adultos con infección confirmada por COVID, para entender cuán fácilmente se habían infectado los niños expuestos a estos casos índice adultos. Un segundo estudio en el que seguimos a más de 2.000 niños de forma semanal prospectivamente en las colonias de verano, como cuasi experimento que nos permitía entender qué iba a pasar cuando se reabrieran las puertas de las escuelas. Y nuestra conclusión fue que realmente los niños tenían un papel menor en esta pandemia. Por un lado, evidentemente, como ya era bien conocido, enfermaban muy poquito, y a pesar de que muchos podían infectarse en una frecuencia parecida a la de los adultos, muchos de ellos no enfermaban, se infectaban sin apenas tener síntomas. Y esto tenía unas connotaciones preocupantes porque pensábamos que podían ejercer de vectores transmisores y de forma silente, puesto que muchos de ellos eran asintomáticos. Lo que pudimos ver en el estudio prospectivo en las colonias de verano, en las que seguimos a más de 2.000 niños, es que su capacidad de transmisión era realmente limitada en comparación a la de los adultos. Y que si las medidas de prevención que se ponían en marcha eran las adecuadas, los niños prácticamente no generaban casos secundarios. Estas lecciones fueron muy útiles, primero para intentar cambiar la percepción de los medios de comunicación que habían acusado a los niños de ser los super transmisores, los super spreaders, intentar cambiar esta visión, y esto nos permitió hacer una propuesta de reapertura de las escuelas, y se abrieron las escuelas con una serie de medidas relativamente estrictas de prevención de la transmisión y de detección precoz y seguimiento de los contactos, y 2 meses y medio después de la reapertura de las escuelas estamos contentos de poder decir que en todo momento menos del 1% de las aulas ha tenido que ser confinada porque estas medidas han funcionado. Con lo cual, en esta breve historia quería simplemente acompañarles alrededor de esta especie de montaña rusa que han sufrido los niños en estos últimos meses en mi país, confirmar que los niños no son los culpables, que los niños además son vulnerables no por la enfermedad, pero por muchas otras consecuencias periféricas de la infección, y que si se hace una buena investigación aplicada se pueden demostrar o confirmar ciertas hipótesis que permiten hacer cambios de percepciones y devolverles algunas libertades a los niños que se les habían retirado en el contexto de esta pandemia. Y aquí lo dejaré y muchísimas gracias.
No, muchísimas gracias. Excelente presentación y creo que es muy importante tocar este tema de los niños que no habíamos tocado profundamente antes. Ahora, thank you. I'm going to ask Dr. Frost to thank her for her patience in waiting to be the very last speaker of the day, last but certainly not least in this session. Dr. Melinda Frost is a leader in global public health communication and education with a focus on infectious disease, immunization, non-communicable disease, and health security. She is currently the Translate Science team lead, infodemics pillar for the World Health Organization's response to COVID. In this role, she represents the risk communication and community engagement response for the organization. Prior to COVID, Melinda led capacity building for the WHO under the Pandemic Influenza Preparedness Framework. She was the Director for Emergency Risk Communication for the US Centers for Disease Control and Prevention in Beijing, China for 6 years, and has also consulted for UNICEF, FAO, and IFRC to assess national existing communication capacity, coordinate multi-sector partnerships, develop communication strategies, and facilitate programs to strengthen national and subnational level communication response. Dr. Frost, thank you so much for being with us. And again, thank you for your patience. We look forward to your presentation.
Thanks. No, it's an honor to be on this panel. And it's really nice to see a lot of the individuals I've been quoting for years. So with that, let me get going. And buenas noches, everybody. It's the evening time here in Geneva. Just as a quick bit of background, I thought I'd plot out sort of where we're at and how we're looking at risk communication across a number of different public health emergencies that we've managed at WHO. If we kind of go back in time, I think that maybe around just post-SARS was when really emergency risk communication hit the forefront of WHO's response to public health emergencies. It became one of the primary 8 pillars under the international health regulations. And it was there that we really began to build this more as a capacity area, both within the organization and then within our member states. And I think it was maybe Dr. Seato mentioned the Joint External Evaluation Tool, where we've been able to work with countries to map out their own risk communications, and also some community engagement capacities. I think this is all going to probably be reshaped post-COVID, but we're looking across these different capacities within emergency risk communications, essentially systems in place, partner coordination, internal and partner coordination, public communications, that's mass and social media, looking at community engagement, and then also the concepts of risk perception and misinformation. So after that, around 2011 or so, we started the Pandemic Influenza Preparedness Framework. Then gave us a little bit more strength to be able to work directly with member states and build their capacity. So during the couple of years I would say over maybe the past 5 or so years, we've been really actively working with different, through our regional offices like PAHO and across the world with different countries, and really building their ministerial capacity to be able to address emergency risk communications and really consider things like risk perception with their populations, and come up with plans, coordinate with other response bodies about how to really effectively, rapidly, transparently communicate with their populations during emergencies. And over the course of the years, you would see that this work became more and more multi-sectoral, knowing that we couldn't just rely, or ministries of health couldn't just rely on the fact that they would be the only voice during an emergency, that they would have to work across many different ministries, and therefore needed to kind of really instill this capacity across any response body during an emergency. We also did a couple other things where we would better be able to deploy emergency risk communications personnel to work during an emergency. Of course, we couldn't deploy anybody during COVID-19, so some of these training programs didn't quite pan out, but we had these individuals already in place in countries. And the other area that we really are beginning to work a bit more on was building under risk communications, the ability to have a stronger social science and behavioral science input into the work we do. So began to also look at that in terms of being able to deploy or build that capacity within the emergency risk communications response system. And so here we are, 2020, what a year it's been, COVID-19. And with that, the whole, I think, landscape from our perspective is going to change a bit in terms of risk communications. I think what you're going to see is that we're going to continue to use the same principles of emergency risk communication, and then change the way we approach things. So now within WHO, I can only really speak really effectively from the global level. We have quite strong capacities at a regional level as well that have more in-depth insight into their audiences and among the member states within the regional offices. But from the global level, when we're trying to communicate with emergency risk communication, we have to really rely on some sort of global data, which doesn't give us a little. And we look at things like existing boards that show us, what information resources countries are most, individuals within countries are most trusting. We also run some digital analytics, what we call our infodemic digital intelligence, where we do social and mass media listening, both in English and French, and more languages are coming up. We've also worked with Imperial College and some other institutions to pull some other more pointed risk perception information. We've looked at things like overall risk perception, but also things like perception of contact tracing, perception of mask use, more specialized points where we've really had to communicate some more difficult science. And so on. So we've been able to kind of pull from different data sources, and that's actually something we're really working closer to, is to get a consistent data sources along the way to help keep informed in our response over the coming year, where we're going to look more behavioral, upkeep of behavioral aspects until vaccine is rolled out everywhere. We've also been working under a framework where we're looking at really being able to build information and communication resources, knowledge and understanding for people, look at more and more at perceptions and practices and so on. And then again, within our regional offices have some pretty strong behavioral and social science that is occurring more so than ever before in any of our emergency risk communications response work. The other kind of thing we're doing is really beginning to look at communities in a different way. While we are definitely working with our partners, primarily UNICEF and International Federation of the Red Cross and a number of dozens of others to work at the country level and really work with communities to really understand individual and community perception of risk and practices and understanding those barriers when it comes to some of the biomedical recommendations that we have. We're also looking at other ways to consider community and communities that have things in common, yet may not be physically present together. So this is just a screenshot of something we've been doing where we're working with youth networks to better understand not only what their perceptions of risk are, how they take on that information, what they do with it, how they can actually help us co-develop information meant for their audiences, which is something we're just starting to do. Is really super exciting and interesting. And we're also doing similar things with employer-employee networks, knowing that they're a trusted source of information, and also faith organizations as well. The other sort of new area, and I think Sander had mentioned this, the whole area of sort of misinformation. And I don't know if you've heard this term, but it's being used quite a bit here at WHO, where we're leading this area of managing infodemics to the point that in the COVID-19 response at the World Health Organization, in our incident management system, we have a pillar called managing infodemics, and that's where the risk communication and community engagement work has been sitting. So there's a seat at the table, and that seat at the table is right next to our COVID-19 experts, right next to infection prevention control, right next to clinical care and everything. So it's just to show how important this has really become in the response and will forevermore be a seat at the table. So when WHO talks about an infodemic, primarily what we're talking about is just the overwhelming amount of information that I think you've all seen and had to deal with yourself. And it's just the issue of not being able to cut through all of that information, and not to say all of that information is bad or false either. Much of it is true. Some of it may be outdated. Some of it may be false. Some of it's misinformation. Some may be even disinformation, but it's just kind of cutting through the noise to get to the information that our target audiences need to get to in order to make the decisions they need to make for the health and well-being of their family. So we've been looking a lot at this, and actually lots of information on our website. We've been doing conferences and trainings and so on, and really tracking sort of the impact of mis and disinformation throughout COVID-19. One of the ways we've been able to look at risk perception is through some work we've done with a Cantor barometer in a number of countries. And it's just less maybe as number oriented as our colleague from, but a little bit fun way to look at things where we scanned individuals' way they're seeking information, whether they seek it more often or not as often, and whether they're more worried or less worried about a situation. And it broke out these different audiences. They're kind of what we call ostriches, people who kind of stick their head in the sand and don't want to know about information around COVID-19 in particular. Que seras, which are pretty relaxed about it and kind of know a bit, but aren't too worried about the rules. Hibernators who accept the situation but don't need to be updated all the time, versus good citizens who both are worried but also have a good balance of wanting to be informed. And then on up the line to distressed dreamers and precarious worriers, with the increase in concern and information seek. So we've been able to kind of plot that out according to age group and sort of see where these different perspectives or perceptions lie in terms of age groups. And then we've been able to kind of think about that in terms of some of the things we're trying to do in the way we're communicating. Like I said, I work at the global level. So when we create communications at our level, it's difficult because I have to think about the grandmother in Costa Rica, and I have to think about the 15-year-old in Kenya, and the 50-year-old man in Lebanon. And these things to some degree have to somewhat resonate with everybody. So again, we have a strong relationship with our regional offices who further define and nuance this information as we go. So we take that kind of all of the data that I showed you before, and that the element of, the different sort of personalities and their risk behavior, and we're plotting it along a line, and then trying to create a package to help support individuals and communities to become their own risk managers, to identify those risks in their lives, where they are throughout their whole day. In this case, we're plotting along the individual, where the risks lie in their family unit, in their home. What about their daily journey, like going to and from the places they go to every day and spend the majority of their time, whether that's work or school or somewhere else. And then their social life and how they can approach safe socializing, and just being able to kind of plot the different points in their life and then see where the potential risks are in terms of COVID-19, and then mitigate those risks for themselves. So it's not a one-size-fits-all approach. It's more providing information for individuals to understand and make their own decisions. As we do this global messaging, we're also doing a community engagement package intended to be used on the ground in the community with individuals. So we're kind of bridging it from two different angles. And so it's through the family unit that we've decided to insert this sort of community engagement type package. And we've tested a lot of these messages just to understand we're using this sort of image of a risk meter. On the left, when the meter goes to the left, it means something, the image that we're showing is showing less risk, maybe physical distancing, mask use, hand wash, covering the cough and so on. And as the needle goes to the right, it indicates higher use. So our tagline here is know your risk, lower your risk. And we did some testing to find out that, yes, in fact, when people see an image and they see the meter going up to red, that they know that that is something that they're not as likely to do in the future. So just taking this and building out communications of all sorts through social media and so on, but ensuring that this information also will be in the community level as well. So we're not just relying on electronic media and so on with this. And then as part of this, we're doing very interactive card games. So that gives a thought process, decision points for the individuals and families. And yeah, little interactive learning when it comes to that too. But that's it. Thank you.
Wonderful, Dr. Frost. Thank you very much. And I think you've demonstrated that we didn't start from zero when we started this pandemic, and also the importance, I think, including and particularly for government representatives of the infodemic. We have to be mindful of that, not just for our employees, but also for the general public. So thank you so much. I just want to encourage panelists, since we've run a bit over time, if you could respond to specific questions within the chat, that would be most appreciative. I think everyone does want to hear more from you, but unfortunately, I think we've run out of time. So it's my great pleasure to thank you for your engagements. Dr. Frost, Dr. Bassett, Dr. Saito, Dr. van der Linden, and Mr. Morgan, thank you so much for being with us today. And I'll turn the floor back over to our friends and colleagues at PAHO. Sebastián Oliel, the floor is yours. Thank you, everyone.
Bueno, muchas gracias y les pedimos un poco más de paciencia a nuestros panelistas para continuar un rato más. Todavía tenemos más de 350 personas conectadas, con lo cual vemos que hay un alto interés en lo que ustedes están exponiendo, así que me gustaría hacerles esta parte de diálogo, por favor se pueden complementar, pero bueno, vamos a tratar de hacerlo breve también. Y me gustaría empezar en realidad con una pregunta que viene en el chat, ¿no? de Nicolás Sepúlveda. Y él quisiera pasar un poco al cómo, ¿no? Porque hemos profundizado mucho en diagnósticos y recomendaciones y algunos han abordado también el cómo abordar ciertas situaciones y me gustaría que profundicemos un poco más en eso. Y una de las preguntas de Nicolás es ¿cómo lograr construir estrategias de comunicación del riesgo en situaciones cambiantes cuando no hay espacio ni tiempo para realizar estudios de percepción con la misma velocidad que se produce la diseminación de un contagio. Si quieren empezar, no sé si Benjamin todavía está aquí con nosotros y quieres comenzar respondiendo, pero siéntanse libres de
I was hoping you weren't going to ask me first.
adelante.
That's a tough one, and I think this pandemic in particular is one where we have seen the research and the science change so fast, so frequently. There's been so much research going on, and it's influencing and changing so often. I think from a communications perspective, an approach that ought to be taken is to take the research and frame it in a certain way. And I'll give you an example. Early on in the COVID pandemic, in Canada anyway, authorities and researchers came out and publicly said, wearing a mask will not help protect you against the COVID-19. Several months later, the message is wearing a mask is required because it will help protect you and your loved ones and the people around you from COVID-19. That created a great, a lot of question, and perhaps created from a public perception, a little distrust or confusion in the research and science. If we had gone back originally and just framed that message slightly different to say, currently, the research tells us, or currently the research suggests that masks are not beneficial, as opposed to making an absolute statement. What that then does is it allows us several months later to say, we care about you so much. We've continued to research, these different areas, and our research now tells us or suggests to us that masks are beneficial. So rather than making absolute statements, positioning or framing communications in such a way that is honest and truthful, that says currently, that allows us opportunity down the road to say, hey, we actually care about this. We take your safety so seriously. We've committed, X number of dollars to research, and we're now learning that. So creating that space through the communications and the perception of community, create the space for the changing research. And I think that's going to be especially important coming up with the vaccines. Every country right now is posturing and positioning, and I know in Canada, making commitments on timelines for vaccine deliveries. I have no doubt that that's going to change as we move into 2021. There will be changes, and I think we need to be very careful about setting expectations that are then potentially going to let our audiences down and create more confusion.
Sí, gracias, Benjamin. Por favor, si el resto de los panelistas quiere agregar algo, me puede interrumpir sin problemas y le damos la palabra. Pero un poco lo que decía Benjamin, ¿no? De no ser absolutistas, ¿no? Con los mensajes en estas situaciones cambiantes, en una pandemia donde estamos aprendiendo de una enfermedad nueva. Y lo que quería preguntar, también tenemos varias preguntas que tenían que ver con la desinformación, las noticias falsas y la infodemia. Y Sander, tú mencionaste que has estado trabajando en este tema también, y OMS también está trabajando en este tema, y quería preguntarles a Sander y a Melinda, ¿cómo es que se puede lidiar con estas teorías conspirativas, ¿no? O sea, ¿qué hace que la gente las crea y las repita, ¿no? Y cómo podemos frenar un poco esta situación. No sé si Sander todavía está, o Melinda, ¿quieres contar qué es lo que ha estado trabajando la OMS también, con los medios también en este tema?
Okay. Yeah, I will say that I think at WHO we're really focused a little bit more on the misinformation. I think what we're mostly concerned about is when there's information that sounds credible, yet isn't quite right. And the ones are really focused on are the ones that can affect people's lives or well-being. And so it could be potentially a cure that's not a cure, or prevention measure that's not a prevention measure. And sometimes it's harmless, but the fact that somebody believes that it would be helpful can be harmful. And then sometimes it's actually deadly. I mean, I think we've seen, unfortunately, some situations where misinformation has led to death. And really what we're trying to do at WHO is just flood essentially channels with what we're just referring to as good information, solid information. And we've done that in a number of really, I think, kind of novel and interesting ways. First of all, we're trying to make sure that we have that information in place in different languages, ready to go. We use it when we use it. And then what we're doing is we're partnering with some big tech companies like, Google, Facebook, all the user, Twitter, everything. I mean, Tinder, everything. You'd be amazed at the number of companies we're working with. And then those companies are actually the ones that will identify when there's misinformation floating around. And then what they do is kind of push forward WHO's or also often local Ministry of Health information to kind of counteract when they begin to see an issue like a misinformation. I think there was one maybe even in your region where there was a questionnaires searches going on a lot on chlorine and bleach and the use of that in order to help prevent COVID-19. And when they saw that, they brought forth WHO Spanish information, and then they noticed that there was a decrease in number of searches on that. So, yeah.
Gracias, Melinda. Y última pregunta me gustaría hacerle al doctor Saito Tomoya. Usted mencionó antes que usar mascarilla en Japón era considerado una norma social, y quería saber un poco cómo es que creen que llegaron a que pase eso en su país y qué consejo tendría para otros países donde esas situaciones no pasan, ¿verdad?
Thank you for a very interesting question, but there is a big cultural difference, even in the seasonal influenza, seasonal influenza, in the winter season, many people wear masks. That is a very high standard. And in February, so the masks are all sold out in our stores, and the attention to wearing mask was very high at that moment. So I don't know. It's quite difficult to make it's a cultural issues, and so it is quite difficult to intervene to or implement the same measure to other countries. We have to customize the intervention strategies for the promoting wearing masks, I believe. Thanks.